Hi, my name is Nguyen. I'm an ultrasound fellow at University of Maryland, where I also finished my residency training. And today I'm going to discuss and update you on how to manage those burns that come to the emergency department. I have no disclosures whatsoever. So managing burns is actually pretty easy, and maybe most of you already know how to manage them. I still get the occasional questions from my fellow colleagues and residents on whether or not to refer a particular patient to the burn center, or whether or not they should consult surgery for a particular burn. And so I'm going to go over some controversial topics and what recent literature suggests on whether or not to debride that nasty blister, how helpful is the Parkland formula, what treatment dressings we have in the emergency department, and if you intend to discharge that burn patient, what good information and what good return precautions you can give them so they know when to come back. So the first degree, second degree, third degree classification does not exist anymore. So we need to familiarize ourselves with the current medical terminology. First degree now is known as superficial thickness. Second degree burns have two parts. They have superficial partial and deep partial thickness. And then third degree is known as full thickness burns. So superficial, they're like sunburns. So they are red, they don't blister, and they can be painful. Superficial partial thickness burns are those of which do blister. They're moist, they do blanch, and they're red. Deep partial thickness burns will blister. However, the majority of it will be red, but there can be some areas that are a little bit more pale. It's not as moist, and they may or may not blanch. And finally, full thickness burns are white, dry, and leathery. One of the most controversial topics is usually whether or not to debride that wound. And historical literature suggests that a blister is a sterile environment, and so it can prevent infection. However, if a blister is actually of significant size, it can actually coagulate and become dense, such that it will cause a pressure necrosis. And this, in turn, can actually convert a burn to a deeper type, necessitating surgical intervention. So current recent literature and practice conventions actually support the debridement of blisters more than 6 millimeters. And it's very important to evaluate that tissue underneath. So the Parkland formula, we're very well aware of it, and we have to know it for the boards. So from a theoretical standpoint, it might be important. However, it has been shown to be inaccurate in proper fluid resuscitation in that critical burn patient. For the most part, what it ends up being is that the patient that you're going to have to resuscitate, it overestimates how much fluid you give. And so then it predisposes them to ARDS and compartment syndrome. So while it's great for boards, it's not so great for practice. The actual best measurement in fluid resuscitation for that critical burn patient is to monitor urine output with a goal of 0.5 to 1 cc's per kilo per hour. So in the emergency department, we're very used to using bacitracin, maybe bacitracin with zeroform, silver sulfadiazine. The Cochrane review suggests that silver-containing dressings will prolong healing time and increase risk of infection. But these are systematic retrospective meta-analyses, so there actually has not been a good head-to-head randomized control study comparing bacitracin with silver sulfadiazine, surprisingly. So we don't really know which is best. You might see this gray foam, which is a silver-containing product. It's non-adherent. It is commonly known as Methylex. It's very popular in the pediatric population, mostly because you can actually just put it on the wound and then have them follow up in a week, and it doesn't require any changes whatsoever. So if you do have it at your shop, it may be helpful. The main point is it doesn't matter what type of dressing you actually use. It's all about maintaining a moist environment, and that's why we ask patients to reapply the medications. So regarding discharging the burn patient, it's really imperative to give them really good instructions so they know what to do when to return. You want to forewarn them about delayed blister development because they might come early after a scalding burn, and it will take a couple hours for those blisters to develop. Educate them on whether or not it's circumferential on a large surface area or if it's on the lower extremities, because it might warrant them to come back to the ED in order to have the debridement done and reevaluation. Lower extremity burns that are partial thickness, so those that blister, really require the patient to be compliant with extremity elevation. And this is mostly because they develop dependent edema, and that actually will decrease their ability to heal their wounds and also it can increase their risk for converting that burn to a deeper type, mostly because it creates a greater distance for the blood supply to actually give nutrients to the dermis. And then subsequently, they might need surgery as well. You can discharge these patients if you think they're going to be compliant with your instructions. And at the very least, if you think that they're going to continuously evaluate their wounds and readdress them, and you think they will return when they should, then it's okay to discharge them. So it's very important to let them know what to be aware of so they can return for that burn. So remember, a significant blister size, if it's circumferential, on a large surface area or on the lower extremities. If they notice any color changes, it's paler, it's white, it doesn't blanch as well, it's much drier, and it's leathery. So those are the important keys to know. So here's a patient who was a 36-week pregnant patient, who actually had was trying to make ramen for her family and developed these blisters, as you can tell. And after debridement, we actually end up classifying this as a superficial partial thickness burn with areas of deep partial thickness. She really wanted to go home, so we gave her strict instructions to elevate her legs, and so that we also gave her return precautions as well, so she knew when to come back. Unfortunately, 2 days later, she probably didn't comply with her instructions as well as she wanted to, because she is a mother with 2 kids. You can tell now that this wound has converted from a partial thickness burn completely to a full thickness one now. It's white, it's dry, it's not as pink and moist. So the important key points to know, so you don't get burned by that burn: debride blisters more than 6 millimeters. Maintain a urine output goal of 0.5 to 1 cc's per kilo per hour for that critical burn patient that comes in, you're going to have to fluid resuscitate. Maintain a moist environment. It does not matter what type of dressing you want to use. And provide really good discharge instructions and return precautions if you plan to discharge them. Thank you.